Okay, hi everybody. Good morning for some, good evening for others. Thanks so much for coming here today. I am Professor Miguel Souza, and together with Professor Marcelo Souza, my colleague from the medical course in the university, in the Federal University of Ceará, will present great authorities talking about GERD and GI motility. During the first hour, Professor Uday Ghoshal from India and Professor Daniel Sifrim from London will show their presentations. During the second hour, Professor Ricardo Oliveira and Dr. Gabriela Bueno from Ribeirão, Preto, Brazil, Dr. Carla Granja from São Paulo, Brazil, and myself will present short case reports. The audience, you, is invited to post comments and questions at any time. I would like also to say thanks to Alassa and also to Dr. Ricardo Viabig for supporting us. Well, let's start. I invite Professor Ghoshal to start the presentation. Professor Ghoshal is from the Department of Gastroenterology in the SGPGI, Lucknow, India. He's president of the Indian Motility and Functional Disease Association and contributes as an editor to important gastrointestinal journals. Thank you so much, Professor Ghoshal. Come in.
Good morning. For me, it is good evening. It is a pleasure for me to talk in this important session on functional esophageal disorder, and also Professor Daniel Sifrim will talk about gastroesophageal reflux disease. So, can you see my slide?
Yes, Professor.
So I'll be talking about high resolution manometry and its clinical utility in diagnosis of esophageal motility disorder. Truly speaking, in this short time, I'll give you the concept, and subsequently through case-based presentation, we'll learn more. Now, obviously, we cannot share everything in half an hour. So if somebody wants to know more, these are the two books on GI motility that we edited, along with Satish Rao and Professor Lee from Malaysia. And I think you are welcome to go through these books. When we are talking about esophageal testing, you have to realize that one thing is we test the structure of the esophagus by radiology, conventional endoscopy, advanced endoscopic technique, esophageal capsule endoscopy, endoscopic ultrasound, and histology. But what happens is this investigation primarily tests the structure of the esophagus, which is altered particularly in organic diseases such as esophageal stricture, esophageal cancer, and so on. But a lot of patients come with symptoms. Those symptoms cannot be sort of explored by the investigation for structure, and there you need esophageal functional testing. And when we talk about esophageal function testing, we are referring to motility testing, which include esophageal manometry, which earlier used to be conventional manometry, but now we talk about high resolution manometry. Also, many machines have impedance technology added to the manometry system. High frequency endoluminal ultrasound primarily tests the longitudinal muscle function of esophagus. On the other hand, esophageal manometry primarily tests the circular muscle function of esophagus. Endoflip is a popular technology now, particularly to assess lower esophageal sphincter. When we talk about reflux testing, we refer to catheter-based pH metry, which in the past used to be single channel, but nowadays we hardly ever do single channel. It is a multiple channel pH metry. But more than that, for diagnosis of reflux today, we talk about impedance-pH monitoring. Bravo capsule monitoring was promoted once upon a time, but I don't think this is a very good technology currently because it is expensive and it does not talk about impedance at all. Mucosal impedance is an emerging technology. When we are talking about transit, we refer primarily to radionuclide esophageal emptying, though impedance monitoring itself during manometry can give an idea about transit. Now, what are the indication of esophageal manometry? Motor dysphagia. So what is motor dysphagia? Dysphagia without any mechanical obstruction is motor dysphagia. Non-cardiac chest pain, gastroesophageal reflux disease, in which case we don't need manometry only to assess the esophagus, but we also need to assess, or we have to localize the LES so that we can place the pH probe in the right place, which Professor Daniel Sifrim is going to talk about in a greater detail. Systemic diseases with esophageal involvement, for example, progressive systemic sclerosis with dysphagia. So there you talk about esophageal manometry. And in patient with dysphagia, when we suspect EUS dysfunction, we may do a body manometry just to tell that the body function of the esophagus is normal. Now, motor dysphagia and mechanical dysphagia differentiation start from history taking. We should not base everything on investigation because investigations are often invasive and they are expensive. Therefore, one should take a thorough history. And in fact, in clinical medicine of current day, this history taking is taking a back seat, but I would say that is not a right approach. So motor dysphagia is typically intermittent. It is dysphagia to solid or liquid together. Many books will describe liquid dysphagia start fast. More with extreme temperature of the food, patient learn that if they raise their arm, straighten their back, the dysphagia becomes less. This is because they try to press the esophagus between the anterior chest wall and the posteriorly the vertebral column. Therefore, they open the LES by increasing the intraesophageal pressure. Motor dysphagia typically is a long duration dysphagia. Episodic chest pain is highly suggestive of motor dysphagia. Regurgitation again is highly suggestive, and it basically means this is a dilated esophagus with retention of the food. And in case of motor dysphagia, weight loss is much less than the mechanical dysphagia. So once we know that our patient is suffering from esophageal dysphagia and not transfer dysphagia. Transfer dysphagia is typically associated with neurological illness where patient will have nasal intonation of the voice, nasal regurgitation of the food, and typically they will say inability to push the food back into the pharynx. Now in those patients, obviously we are talking about transfer dysphagia. But when somebody does not have transfer dysphagia, it is esophageal dysphagia. The first job of the clinician is to differentiate whether we are dealing with a patient of motor or mechanical dysphagia. And if this patient is suffering from motor dysphagia, we investigate the patient. In the past, barium swallow was a popular investigation, but nowadays we know that barium swallow is a very crude test, but sometimes in patients with motor dysphagia, it can give idea such as megaesophagus. So what is megaesophagus? It is an esophagus which is dilated 7 centimeter or more, and these patients often don't do well with esophageal balloon dilatation or pneumatic dilation. Now, there we replace the barium esophagogram with timed barium esophagogram because timed barium esophagogram gives a better assessment of esophageal emptying. In this, we give 100 ml barium, 45% weight by volume. We take X-ray at 1 2, and 5 minutes. We look at the height of the barium at 1, 2, and 5 minutes. Sorry for the mistake here. We also see volume at 5 minutes, and this represents esophageal emptying. Therefore, it is related to lower esophageal sphincter pressure, which is increased in some patients with motor dysphagia, such as achalasia cardia, but more often they have a non-relaxing LES, and therefore their emptying is impaired. But let us talk about esophageal manometry, which is the gold standard investigation for patient with motor dysphagia. Now, earlier we used to do conventional manometry, so I'll touch on this little bit so that we understand what is new in high resolution manometry. Now, this manometry could be water perfusion manometry or solid state manometry with impedance. We have both the system in our laboratory. Only problem is in many countries, typically the developing countries, where the cost of care is very important, I find that solid state manometry is quite expensive. Now, the catheter could be water perfusion. Here we have the catheter which contain multiple capillary tubes. Now, these multiple capillary tubes open at different locations along the length of the catheter. Now, through this tube, water is perfused at a constant rate, and whenever there is a lumen occlusive contraction in the esophagus because of circular muscle activity, actually there is impedance to the flow of water. And this impedance to the flow of water leads to increase in the pressure, which through the transducer is actually recorded as a digital signal in the computer screen. On the other hand, in solid state catheter, typically you have two metal rings, and these rings actually, whenever these metal rings come close to each other because of circular muscle contraction, this leads to variation in temperature locally, which is actually recorded by the system. Obviously, I told you that manometry typically assesses the circular. I'll show you later with the current high resolution Klaus plot. Actually, you get a good idea of the longitudinal muscle activity as well. Now, let us say this is the esophagus, and you can see those round yellow circles represent the manometry port. Now, when a fellow swallows, what happens is that the bolus goes through the esophagus. Obviously, esophagus contract and relax in different locations. So the location above esophagus is contracting, but at the same time, location below it is relaxing, and that leads to propulsive activity, which propels the bolus into the stomach. And this propulsive activity is recorded by the manometry system. This is the port at lower esophageal sphincter, and as you can see here, when the pharyngeal activity starts, simultaneously as a reflex activity, lower esophageal sphincter relaxes, and it remains relaxed till the bolus has crossed the lower esophageal sphincter and entered into the stomach. And obviously, after the bolus has crossed, there is a rebound increase in the pressure, then the LES pressure comes down to the baseline. Now, what is high resolution manometry? Now, if you have to understand what is high resolution manometry, it is good actually to understand what is conventional manometry. In the conventional manometry, the x-axis represent the time and the y-axis represent the amplitude of contraction. So y-axis represent the amplitude of contraction, x-axis represent the time. And when the swallowing occurs, the muscular activity increases the pressure, and this pressure is recorded like an upward and downward deflection. Also, you have to understand that most conventional manometry system had lesser number of port. For example, about 30 years ago or 25 years ago, when I was doing manometry in our laboratory, typically it used to be 6 or 8 port conventional manometry system, where 2 port used to be in the ileus, 1 port used to be in the stomach, and the remaining 4 or 5 port used to be in the esophageal body. So therefore, what happened is it had a limitation. What was the limitation? The limitation was here. So what happens is, let us look at this diagram. This is only maybe 6 or 8 port on the left side. Now, if there is a sweeping contraction like this, which squeezes the manometry catheter, but the squeezing occurs in the location between the port, this particular peristaltic activity will not be recorded. On the other hand, current high resolution system has large number of port, for example, typically 32, even we have 64 port manometry system. Therefore, there is no way that such contractions will be missed by this system. Second thing is, I told you the conventional manometry, x-axis represent the time, y-axis represent the amplitude of contraction. Now in the high resolution manometry system, x-axis represent the time, y-axis represent the esophageal length. So therefore, how do you represent the amplitude of contraction? This novel idea was brought in by this gentleman, Klaus. So Klaus, what he did is, to represent the amplitude of contraction, he gave color. So he coded color, and I have given an analogy to this color coding in the high resolution manometry system. If you look at the nature, sea is blue, and deeper you go, it is more deep blue. Then you go to the paddy field, it is beautifully green. If there is a setting sun in the sky, you can see yellow and red, and at the top, you can see the black color. So therefore, the manometry has similar color coding, very easy to remember. More blue means negative pressure, more black means high pressure, and there are varying shades of green, yellow, and red in between. So this is called Klaus plot, where an esophageal length is represented in y-axis, time is represented in x-axis, and the color gives you actually the amplitude of contraction. Now this is an example where you can see this is upper esophageal sphincter, high pressure zone. This is lower esophageal sphincter, which is again a high pressure zone. Above this EUS, you can see negative pressure, which is pharyngeal pressure. Below the LES, you can see negative pressure, which is intragastric pressure. And between the LES and the EUS, you have negative intrathoracic pressure. In between, with each swallow, you can see the contraction of the esophagus, which are sloping, means these are peristaltic. Now, we all know peristalsis can be primary, can be secondary, can be tertiary. So what is a primary peristalsis? Primary peristalsis is a swallow associated peristalsis. So therefore, all the primary peristalsis will have EUS relaxation, through which bolus has entered from the pharynx into the esophageal body and then passed through the ileus. What is secondary peristalsis? Secondary peristalsis is in absence of swallowing. So therefore, it will not show any EUS relaxation. Typically, nature has given this mechanism to clear the refluxate, so that off and on the reflux that we have of the content of the stomach into the esophagus actually is pushed back into the stomach, so that there is no damage to the esophageal mucosa. And tertiary peristalsis is something like atrial fibrillation. It is typically the flickering contraction, which does not have much physiological significance. So these are the three types of peristalsis. Also in high resolution manometry, there is a zone just below the upper part of the esophagus, where you will get a pressure activity which is quite broad. It is a broad or a longer pressure activity, but it is a low pressure zone. So what is the explanation for this broad low pressure activity in the upper part of the esophagus? This is related to the muscle composition in that area. The muscle composition is that you can see in this area a varying proportion of muscle are either are skeletal as well as smooth. In the rest of the esophagus, you have only smooth muscle. But in this location, maybe 50% are skeletal muscle, 50% are smooth muscle. And we all know skeletal muscle is in response to a stimulus contracts very fast. But again, it becomes, or its contraction also disappear very fast. So it has a typically upward spike very quickly and then downward or downstroke also quickly. On the other hand, smooth muscle has plateau type contraction, but its contraction duration is quite long. So when 50% of the muscle are skeletal, in response to a swallow, they will contract very quickly, but the remaining smooth muscle will join the skeletal muscle later and will this contraction of the 50% smooth muscle will last longer. So therefore, all the muscles in this region are not working simultaneously. That's why it is broad. And because they are not working simultaneously, it is low in amplitude. Now let us look at the mechanism of swallowing. This is the esophagus. Now the moment a bolus enters into the esophagus, there is an increase in the pressure in the esophageal lumen. And this is called intrabolus pressure. Now you can see here, the moment upper esophageal sphincter muscle has opened, the color of this blue zone has become lighter. So lighter blue means higher pressure. And this lighter blue represent intrabolus pressure. The moment bolus enters, there is an intrabolus pressure. Now subsequently, what happens is, there is a contraction above this bolus, and this is the esophageal contractile front. So you can see here, this is the esophageal contraction or esophageal contractile front. Now simultaneously, the ileus relaxes. Now when the ileus relaxes, still there will be some pressure. Earlier we used to call it as a nadir pressure, but now the terminology is changed. And this terminology is integrated relaxation pressure, which I'll explain. So what is integrated relaxation pressure? This is a pressure, this is the minimum average pressure in the ileus region, over a 4-second window, which need not be consecutive. So this is minimum average pressure in the ileus region over a 4-second window, which need not be consecutive. That is called integrated relaxation pressure. Now what happens is, if the integrated relaxation pressure is low and there is a good gradient between the esophageal contractile front pressure above and integrated relaxation pressure below, the bolus moves. So this is the normal physiology. So when does dysphagia occur? When esophageal contractile front is very weak, and obviously the gradient between contractile front and IRP does not occur. Or when esophageal contraction is simultaneous, so that it doesn't propel the bolus, but it squeezes the bolus. Or when esophageogastric junction pressure or IRP is quite high. These are the three situations where dysphagia would occur. So the concept of integrated relaxation pressure, I already told you. So therefore I skip this slide. What is the concept of DCI? DCI is distal contractile integral. So distal contractile integral, typically you calculate in a zone which is below the transition zone. That means it starts from here and till this deceleration point, which I will explain later. So what is DCI? DCI is amplitude of contraction into duration of contraction over an unit length of the esophagus. So it is amplitude of contraction into duration of contraction over an unit length of the esophagus. So what is CFV, or contractile front velocity? So if we know that when the contraction occurred here and when the pressure front rose here, now obviously there is a time gap between these two. So if we know how much time did it take for the contraction to come from this location to this location, and obviously from the catheter mark we know how many centimeter is this, so we can calculate CFB as distance in centimeter divided by time in second. CFB is supposed to be less than 8 centimeter per second. That means it should be less, it should not be more. If CFB is too fast, that means it is moving too fast, more than 8 centimeter per second. That means there is lack of distal latency. So distal latency is less, and distal latency less means this is a simultaneous contraction or premature contraction. So currently in currently in Chicago 3 system, we have actually realized that CFB is not as important because distal latency gives us an idea whether the contraction is simultaneous or not. Now, I will not touch on impedance because impedance is a system which gives you flow of the bolus through the esophagus, and only some manometry system, particularly those which are solid state system, has impedance inbuilt into it. And currently Chicago system did not lay too much importance on impedance technology, but with time to come maybe it will become important. Since I have given you a little brief, I want to tell you how important a well done esophageal manometry is through a case story. This is a 19-year-old son of a doctor. He himself is a medical student. Now this fellow started having dysphagia, regurgitation, and occasional heartburn, but no chest pain for 1 year. So he had dysphagia as a symptom, he had regurgitation, and he had occasional heartburn. Upper GI endoscopy done elsewhere was normal, and a high resolution manometry elsewhere diagnosed him having type 1 achalasia, and therefore a POEM or paroral endoscopic myotomy was planned. He also underwent a barium swallow which showed somewhat dilated esophagus without any parrot beak. Now see, since his father was a surgeon and he himself was a doctor, he thought before undertaking this POEM, which is quite irreversible sort of operation, he thought he should take a second opinion. Therefore, he came all the way from Calcutta to Lucknow for a second opinion. So he repeated the esophageal manometry. And what we found is, yes, there is some very low amplitude contraction, hardly any. It looked somewhat simultaneous, but not really. But what happened? It is relaxing alias. Because on impedance, we could find that his bolus was flowing beautifully in the stomach, as you can see here. You can even overlay on the pressure activity, and we found that there was not much bolus escape. So there was beautifully the saline was going into the stomach. We actually played this video for you, and you can see here each time there's a contraction activity actually. So bolus is going to, if you want me to play once more, let me play. You can see here the bolus is going to the stomach and then it is refluxing back. So we thought he may be having pH metry and it was grossly abnormal. So what was happening is he may be having a esophageal muscle disease, something like the esophageal muscle, something like a scleroderma. Physiology, he has a low LES pressure, but it is relaxing very well because he has hardly any muscular activity. the manometry done earlier misinterpreted this movement of catheter as simultaneous contraction activity and led to an erroneous diagnosis of achalasia cardia, and he was going to undergo a poem. So you can understand a well done manometry is very, very important. Now also, when you see a patient of achalasia, be aware of pseudo relaxation. What is pseudo relaxation? When you do a high resolution manometry, when the patient swallows, circular muscle actually squeezes the catheter, but longitudinal muscle shorten the esophagus. And because of this shortening of the esophagus, actually the ileus gets pulled up. Now, in conventional manometry, sometime, and even some high resolution manometry also, I have seen some people places his window for IRP here, and you can think that this esophagus is relaxing or this ileus is relaxing, and therefore it may not be achalasia. This is actually pseudo relaxation. This is happening because the longitudinal muscle is pulling up the ileus. So this is pseudo relaxation. So this is Chicago classification, algorithm 3 or version 3. If you have done a manometry, look at integrated relaxation pressure first. If integrated relaxation pressure is greater than upper limit of normal, if it is greater than upper limit of normal, that is 15 millimeter of mercury per centimeter per second. Oh, sorry, 15 millimeter of mercury. So then what happens is you look at the peristalsis. If peristalsis, if IRP is equal to or greater than upper limit of normal and 100% absent peristalsis or failed peristalsis, look at the esophageal body contractility. If there is no contractility, this is type 1 achalasia. If there is a pan-esophageal pressurization, this is type 2 achalasia. And if there is a segmental spasm with a distal latency less than 4.5 seconds, this is type 3 achalasia. On the other hand, if IRP is greater than or equal to upper limit of normal and the patient does not have simultaneous contraction as mentioned above, this means this is not type 1 or type 2 or type 3 achalasia. This is esophagogastric junction outflow obstruction. It may be an early stage of achalasia or it may be a mechanical obstruction. These two groups of disorder are together called disorders with EJG outflow obstruction. Now, if IRP is not like greater than upper limit of normal, that means IRP is normal, but the distal latency is short, like less than 4.5 seconds, and high DCI, so distal contractile integral is very high. I'll tell you later what is high. Then it can be DS. In DS, 20% of the contraction will be premature contraction, which means distal latency is less than 4.5 seconds. Jackhammer esophagus is greater than 20% had DCI of more than 8,000 millimeter of mercury per centimeter per second. Absent contractile activity, sorry for the mistake here. So absent contractile activity, I showed one patient where there was a muscle disease maybe in the esophagus. So therefore hardly there was any peristalsis. And these are major disorder of peristalsis which are not normally seen. Now, if IRP is normal and 50% or more have ineffective swallow, this is classified as ineffective esophageal motility, greater than 50% or equal to 50% ineffective swallow, or fragmented peristalsis. Fragmented peristalsis where more than or equal to 50% are fragmented. That means there is a large break in the peristalsis. These are minor disorder of peristalsis and impaired clearance. If IRP is normal and greater than 50% effective swallow, this is a normal manometry pattern. Now, these are like the sort of cutoffs Contraction vigor, failed means DCI less than 100 millimeter of mercury per second per centimeter. Weak means DCI between 100 millimeter of mercury per second per centimeter, but less than 450 millimeter of mercury per second per centimeter. Hypercontractile is DCI more than 8,000 millimeter of mercury per centimeter per second per centimeter. What is premature contraction? Distal latency is less than 4.5 seconds. What is fragmented peristalsis? When there is a large break, for example, more than 5 centimeter break in 20 millimeter of mercury isobaric contour with DCI more than 450 millimeter of mercury. Because if DCI is very low, it can be something like a very weak peristalsis or fatal peristalsis. And if none of the above are fulfilled, then this is intact peristalsis. Now, achalasia is further classified, as I told you, type 1 achalasia, where no esophageal pressurization exists. IRP is more than 15 millimeter of mercury, though in some studies, authors use more than 10 millimeter of mercury IRP as abnormal for type 1 achalasia. Why is it so? Because this esophagus does not have any contractile ability. Therefore, even if IRP is 10 or more than 10, 11, it cannot push the bolus. Type 2 achalasia is panesophageal pressurization like this with IRP more than 15 millimeter of mercury. Type 3 achalasia is segmental esophageal pressurization with IRP more than 15 millimeter of mercury. Obviously, my introspection is type 3 is the earliest disease, type 2 is little more advanced disease, and type 1 is the most advanced disease where esophageal muscle is totally gone because of denervation maybe. Therefore, truly speaking, type 1 should have been called type 3, but this is how terminology is. And type 2 achalasia responds best to the pneumatic dilation. The reason is very clear. Type 2 achalasia is the one where the muscle is still there. So therefore, esophageal body muscle is still there. So therefore, if we disrupt the non-relaxing LES, the muscle can actually squeeze the bolus down into the stomach. It is like a fellow who has, let us say, aortic stenosis. If you do an aortic valvotomy at the early stage of the disease, the fellow will be having better cardiac output than a patient of aortic stenosis having hugely dilated left ventricle with flaviventricular muscle. There, if you do aortic valvotomy, the response will not be as good. The analogy of this outcome is there only. So what is the value of esophageal motility and achalasia? It is gold standard for diagnosis. It differentiates DS from achalasia. Sometimes even people, when they did not develop fluoride picture on barium endoscopy or even in manometry, you can actually tell this looks like achalasia. Post-pneumatic dilation LES pressure measurement suggests adequate of pneumatic dilation. Response, I will show this. Pain of a vigorous achalasia. Earlier, type 3 achalasia or even type 2 achalasia was called vigorous achalasia, and this patient has pain as a major symptom in addition to dysphagia. And if you do pneumatic dilation, pain may not respond to dysphagia respond. DS may require a different treatment approach than achalasia. What is the value of esophageal manometry in GERD? I'll not touch on this because obviously Professor Sifrim is going to talk about this. LES pressure power studies found that if after pneumatic dilation you reduce the LES pressure to below 22.5 millimeter of mercury, you have done a good job with a sensitivity and specificity to predict the outcome to the tune of 60 to 80%. But if you have reduced the LES pressure below 10 millimeter of mercury, you have done great job and they often, their response lasts longer, as shown here. There was also a good study from Michael Veggie's group, where actually they looked at time varium esophagogram and not manometry. So what they looked at, is in time varium esophagogram, if after pneumatic dilation you do a time varium esophagogram, there will be a group where time varium esophagogram has shown that there's a good yes disruption or good esophageal emptying. Another group had symptom relief, but the time varium esophagogram concordant group, and the securing follow-up after the dialogue was asthmatry was actual solution manometry, a lot of limitation, and we have to accept that this conclusion may not be very valid. Now let me show you a few examples and then end here. This is a normal manometry. This is a patient where there is a long transition zone or peristaltic break. This is a patient where there is a total peristaltic failure with low LES pressure, which may be associated with progressive systemic sclerosis with esophageal involvement. But you can see similar pattern in patient of severe GERD or type 1 achalasia following dilatation and poem. And this is a patient who has a hypercontractile esophagus. You may call it jackhammer esophagus. Esophagogastric junction morphology. But because I'm already crossing my time, I will not elaborate on this in detail. This is actually based on whether the smooth muscle LES and the diaphragmatic pinch cock, they are together or they are separated. But I tell you, the clinical significance of this is yet to be sort of validated. Now, I was talking about Chicago 3 only. I did not refer to Chicago 4. Daniel, Sifrim, and I participated in Chicago 4 classification, and it is expected to be published in Neurogastroenterology and Motility soon, but I did not talk about it because still it is published. It is embargoed. Thank you so much. It was a pleasure sharing with you the esophageal manometry high resolution in investigation of esophageal motility disorder.
Thank you for the fantastic conference, Professor Ghoshal. I'm presenting myself. I am Professor Marcelo Souza from Fortaleza, and I'm the moderator of this section. I have a question from Hari from to Professor Ghoshal. Is type 3 achalasia a distinct pathophysiology entity as compared to type 2, type 1 achalasia, or all three are in the continuum with regard to the disease progression? What is your opinion, Professor Ghoshal?
Yeah, it is a very good question, I tell you. Actually, we believe that this is a continuum. And there are some data on this. People have shown that DS patients progress to different subtypes of achalasia. And in fact, we wrote a review article in this in World Journal of Gastroenterology. If somebody is interested, can go through. What happens is, what we believe is that initially there is a degeneration of nitrinergic system. And nitrinergic system is responsible for delay in the contraction in the lower esophagus, because normally nitrinergic neurons are in greater concentration in the lower esophagus than in the upper esophagus. This is based on studies in monkey esophagus from Raj Goel group. Now, this leads to normal peristalsis. Otherwise, actually, esophageal muscle is a syncytium and it is supposed to contract together. So initially, nitrinergic degeneration lead to simultaneous contraction. But at that stage, cholinergic activity is still intact, and therefore the cholinergic activity leads to hypercontractility. Now later, because of the Wallerian degeneration, maybe people have shown Wallerian degeneration, the biggest now in patient of achalasia cardia. They have even showed Lewy bodies in the brainstem, which occurs in degenerative diseases of the nervous system, for example, Parkinson's disease. The cholinergic system also degenerate, and that leads to type 1 achalasia. So it is a continuum, but a continuum need not be true for every patient. It is like in some patient, you can get for the first time, they develop symptom and you find he has type 1 achalasia, but we don't know how long did he have asymptomatic disease, but I believe it is a continuum largely.